Thank you all. What a great way it's hard to follow Dr. Fry, and we're just so proud to have you here, Dr. Fry, and as the Vice President of the American College of Cardiology. We're just so thrilled to see what the future will bring with all your incredible innovative thoughts and the driving force that you will be in healthcare for us. So thank you for being here and delivering that wonderful lecture. So, of course, Dr. Sharma, thank you for giving me such a difficult task to talk about retiring, something we've been used to for all of these years, decades of aspirin. Important for you to note my disclosures. Specifically, I'll be talking about the Twilight Trial, which was a study that was investigator-initiated, sponsored by the Icahn School of Medicine, but through a significant grant from AstraZeneca. So it's our wonder drug, isn't it? You take an aspirin, it's better than an apple, keeps the doctor away. It's the real thing, and Bayer has really enjoyed the benefit of how it has been warning everything, including dementia, all kinds of cancer, everything you can imagine. And it really, truly has been the drug. And we shouldn't throw the baby out with the bathwater. This is really tremendously an important drug that has helped us fight heart disease and reduce the ischemic burden of cardiovascular disease and reduce ischemic events. So let's not forget that. But very important is that aspirin's platelet inhibition is something that we've all been extremely interested in, obviously, because of the pathobiological mechanisms. It works through the thromboxane A2 pathway, but it has had roles in coronary atherothrombosis, venous thromboembolism, colorectal cancer, and also cognitive impairment. So why would I want to retire such a fantastic drug? And I'm not so sure that I want to, but I want to take you through this and for us to maybe perhaps think about some novel strategies that might work better than keeping aspirin on for the rest of their lives indefinitely. And I'll go through the primordial prevention, primary and secondary, and even tertiary prevention in the different strategies and how we could think about perhaps tailoring some therapies as we see patients going forward. So let's begin with the primary prevention, primordial prevention. This has been a 30-year journey for aspirin with incredible positive results and effectiveness, but recently, it's not been that great in primary prevention. A lot of null effects and neutral results, and the price of bleeding that patients have to pay for being given aspirin for primary prevention. And I think it's been especially the last couple of decades, and maybe this has to do with the fact that thanks to Dr. Libby, we understand inflammation better, and we're doing other things, and our risk profile and the risk assessment and the risk of patients are not where they were 30 years ago with all of the contemporary drugs that are now available, including ACE, ARB, ARNIs, PCSK9 inhibitors, statins, and of course SGLT2 inhibitors now. And you start to think about why is it that we're not seeing that benefit that we used to see. And here's some of the contemporary trials of aspirin in the recent years, double-blind, placebo-controlled, lots of them, some are even open label. And for long periods of time with long-term follow-up, up to like 7.5 years in ASCEND and in Aspirin, 5 years, 6 years in ARRIVE, and of course, event-driven, open-label, randomized clinical trial of ACCEPT-D. And you start to think that they're actually, even for primary prevention, put in patients at a higher risk, the elderly, the diabetic patients. And what did we find? Modest, if not really nil effects, little to no benefit. In ARRIVE, there was no benefit. In Aspirin, elderly, no benefit. In diabetes, ASCEND, yes, there was some benefit, but it was marginal and not as great as you might have imagined. And the harm was absolutely there for each and every one of these trials in terms of bleeding. And so it really kind of brings you back to the question that should we just be giving aspirin to anyone who's over the age of 55 and is a diabetic or, has moderate risk factors for cardiovascular disease? And I think the answer is no, given what we've learned recently. And I think the meta-analyses even, maybe not one trial is completely powered to answer all those questions that I said, but the meta-analyses that have now been forth continue to show us the harm of major bleeding in red. Some benefit, but those benefits the risks are beginning to outweigh the benefits. And I think that's when we start to rethink the role of aspirin in primary prevention. What do the guidelines say? Very, very tough guidelines from the 2021 ESC guidelines on prevention for cardiovascular prevention. Antiplatelet therapy is not recommended in individuals without CVD due to the increased risk of bleeding. That's a class 3 recommendation. The 2019 ACC/AHA, the low-dose aspirin might be considered a 2B, but the class 3 is there. That you shouldn't give it in a routine basis. And I think it's and especially because of the harm of bleeding. So there is primary prevention. What about secondary prevention? Well, there the role of aspirin can't be, underestimated. Way back when, in 2009, the ATT collaboration, the anti-thrombotic or thrombosis collaboration, did this meta-analysis, 17,000 patients and 16 randomized trials, and just to sort of see why was aspirin the cornerstone of therapy. Take a look at the major vascular events, coronary events, and strokes. For treating every 10,000 patients with aspirin for 1 year, reduced 100 to 200 ischemic fatal and non-fatal events. This is not a small thing. It really is a real deal. Aspirin is doing something great here. And the price was some extracranial, especially GI bleeding, but it was only 10 to 20, so the calculus seemed to work, right? The math works in favor of using aspirin for secondary prevention. And the hemorrhagic strokes was only one in treating 10,000 patients for a year with aspirin. So it just makes no question that this becomes the cornerstone of treatment in DAPT. And when we go to a single antiplatelet therapy in secondary prevention, it's the P2Y12 inhibitor that we usually use to drop and keep aspirin on board indefinitely. But let me tell you why I think there's a great rationale for aspirin-free strategies in secondary prevention, especially after PCI. And I think I already alluded to the fact that the risk reduction with contemporary drugs makes our patients, favorably affects the patients such that their risk is no longer as high as it was 2 decades ago. It's a lower risk, so what's the price? How much more effectiveness are you going to get out of aspirin when you already have all these amazing other drugs and you've already reduced those important risks tremendously? And we have novel antithrombotics, and they're available. These are new compounds with potent antithrombotic efficacy. And it makes you think about, when you have potent agents, why do you need a weak antiplatelet, such as aspirin? And then let's never forget the direct gastrotoxicity that aspirin has. And I know there are now new formulations of aspirin where it doesn't become active until it gets into the duodenum, so the gastric bleeding will go down into the duodenal bleeding. I think that's what will happen to Vazalore, which is what we're hearing is out there. There's definitely a different formulation, and maybe it will be effective in reducing gastric bleeding, but the intestinal bleeding may still be there. And I think it's very important to kind of not estimate that risk of bleeding. It happens, gastrointestinal bleeding is a lot more common than stroke or hemorrhagic, than stroke or even a myocardial infarction, especially given everything else that we have in front of us. So these three major important reasons, I think, are the reasons why we need to think about novel strategies. And this has been on the gastrotoxicity, it's been really very, very well worked out, where there is this direct gastrotoxicity where you really are seeing an important effect there outside of the antiplatelet effect of aspirin. So maybe it's not such a glorious drug. We talked about the gastrotoxicity. The enteric-coated formulations may or may not be. You have to be careful because these are, in fact, they don't mitigate gastric erosions, and we actually know that they're also associated with gastric erosions. And in fact, in some places, there is some drug absorption issues that actually lead to less of platelet inhibition. And most of our patients are on enteric aspirin that's probably doing not that much of a good job in platelet inhibition, but still eroding the gastric mucosa. So it's a very, very important situation to think about. And there's been pharmacokinetic and pharmacodynamic studies that have been done. This was done by Paul Armstrong a decade ago. It wasn't like we just came up with this brilliant idea that we should withdraw aspirin, where he showed, and others have shown with ticagrelor, this is with prasugrel, that in the presence of a potent P2Y12 inhibitor, aspirin is really, really not doing much more in platelet inhibition. This was in vitro assessment of platelet aggregation with 4 agonists in presence of aspirin and the prasugrel active metabolite. And you can see little to almost no additional platelet inhibition following these stimuli that you see here, collagen, adrenaline, TRAP. And of course, it brings us back to the P2Y12 receptor inhibitor, or the P2Y12 receptor, as a very important receptor that plays a central role in platelet activation and amplification. This has a major role in, we've seen established clinical efficacy with reduced stent thrombosis, and of course, a very important pivotal role in P2Y12 mediated signaling on thrombotic and inflammatory processes. So makes you think, well, maybe we're dropping the wrong drug at the end of our dual antiplatelet therapies. And it comes to at a point where we saw the Plato trial with ticagrelor in ACS patients versus clopidogrel, showing a tremendous, a 16% relative risk reduction in all acute coronary syndrome patients in terms of cardiovascular death, MI, and stroke. And it was a very important addition to the armamentarium of treating patients with acute coronary syndromes. It was a potent, reversible drug, BID dosing, with excellent results. And it did increase bleeding, because what you're seeing there, no difference, is their definition, but non-cabbage related bleeds were definitely increased. But to me, this was the most telling part of the Plato trial, where there was a very important relationship in the efficacy of how well ticagrelor did to the dosing of the aspirin, such that you started to see the worst effects. And in fact, that was mostly in the United States, where at that time we were using high-dose aspirin with ticagrelor. And in fact, the lowest dose of aspirin is what was really, really the most effective. And for that reason, we have a black box warning against the use of high-dose aspirin in combination with ticagrelor. So if less is more, can none even be better? That's something that we need to think about. And the dropping of the aspirin and going to a P2Y12 monotherapy started in Asia, where we see patients who are at high bleeding risk and low ischemic risk. And these patients, at STOP-DAP2 trial with 3,000 patients randomized to a dual antiplatelet therapy for 12 months versus clopidogrel alone after a month of dual antiplatelet therapy, or the SMART Choice trial with another 3,000 patients in Korea, where they also did the same at 3 months, going to a P2Y12 monotherapy, mostly with P2Y12, versus DAPT for 12 months, showed no difference in ischemic events and, of course, a reduction in bleeding. And that was a very, very important telling sign. And the global leaders, investigators with close to 16,000 patients, the largest PCI ever study, where they actually looked at a experimental strategy to make it simple and give everyone ticagrelor plus aspirin followed by ticagrelor monotherapy for the next 23 months versus DAPT for 12 months and going to an aspirin alone strategy. And they found absolutely no difference in the hard endpoint of all-cause death or new Q-wave MI. The sad part about this trial is that they wanted to show that they would actually reduce death and Q-wave MI. And to me, when you drop aspirin and you're getting no difference in your ischemic events and you're gaining on bleeding events, you begin to think that's a winner. That's a winner. We can drop aspirin. But unfortunately, that wasn't what was taken away. When you miss an endpoint of your superiority, it's a missed primary endpoint and people ignore your trial. So we designed the Twilight Trial. This was a trial that was very much worked on with Dr. Sharma, who's here with me as one of the highest volume operators, where I saw that he was treating patients who not necessarily had acute coronary syndromes, but they were complex patients with complex PCI going home on aspirin and ticagrelor. And we sought to understand, can we drop aspirin after a certain period of time? So we designed the study with an open enrollment period of 9,000 plus patients with high-risk PCI, in whom the clinician wanted to send the patient home on aspirin and ticagrelor. At the end of 3 months, all patients came in for a visit. We counted their pills. We made sure they were adherent and didn't have major ischemic or catastrophic bleeds. And if they met that hurdle, they were then qualified to be randomized in our double-blind placebo-controlled trial, where we gave patients ticagrelor plus aspirin or ticagrelor plus a matching placebo, and then followed them with phone calls, in-person visits, followed their adherence, and brought them back at 12 months after randomization, and then observed them for another 3 months after the unblinding after the completion of the study period. We put in these criteria to be sure that we had complex patients for both bleeding and ischemic events, and you can see. But what's most important on this slide is who the Twilight strategy is not for. STEMI patients, salvage PCI, someone on a chronic oral anticoagulation, prior stroke, or planned coronary revascularization. I often think that we focus too much on inclusion criteria. We should look at who was not in the study and who this doesn't pertain to. So it's really important to note that. Our primary hypothesis was that we would reduce bleeding. And boy, if we didn't reduce bleeding, then we were doing something really, really wrong. And the primary hypothesis was this, and if you left your patient that you wanted to treat on aspirin and ticagrelor, as we do for 12 months, the BARC 235 bleeding was at 7.1% down in the year. And if you just dropped aspirin, you brought that down to 4% with a 44% reduction, an absolute risk reduction of 3.1%, with the numbers needed to treat of 33. Well, that's all good said and done, but what was really important is to be sure, and why we needed 7,000 plus patients, is to be sure that we would meet the non-inferiority margin for the hard endpoint of death, MI, and CVA. And that's exactly what we looked at, death, MI, CVA, and the New England Journal allowed us to keep this in the abstract. They no longer allow secondary endpoints. This was a key secondary endpoint. And here's what we did. Here's the aspirin plus ticagrelor, and here's what happens when you give the patient placebo. Absolutely no movement. These curves are hugging each other throughout the study period with no significant difference, meeting the non-inferiority margin. So this was a clear winner in a way to go ahead in that select patient group. Our Korean investigators followed this with STEMI and non-STEMI patients with the TICO study with a randomization to 3 months of DAPT followed by ticagrelor monotherapy versus 12 months in that patient population, and found very similarly a major reduction in bleeding, no change in ischemic events. This was only 3,000 patients. They had a NACE endpoint, net adverse clinical events, in favor of a 3 months therapy. And we then performed a massive IPD analysis in BMJ that was just recently published that basically shows that when you go to a P2Y12 monotherapy, you will reduce bleeding of the hardest endpoint of BARC 3 and 5, not just BARC 2, 3, 5, but BARC 3 and 5 significantly reduce bleeding, and you will not be causing ischemic harm. And in fact, you're trending towards less ischemic harm when you do that. This was in 24,000 patients. And the ESC guidelines actually gave ticagrelor monotherapy a 2A recommendation in that select group based on all of the data that we had made available. This past ACC, though, in the acute coronary syndrome patients, our Japanese colleagues continued their STOP DAPT2 study that they had completed that I showed you earlier on with clopidogrel monotherapy, and they had about 36% ACS patients. Then they randomized another 2,000 patients, so they had about 4,000 patients in their STOP DAPT2 ACS. They looked for non-inferiority. They went to clopidogrel monotherapy in ACS patients, and here they did not meet their non-inferiority margin, and they failed to attest non-inferiority in ACS patients going to clopidogrel monotherapy, which makes you think that maybe this is not for everyone, and in certain patient populations we may think differently. And I also want to pay attention why I think we need to rethink our indefinite aspirin to a study that was conducted in Korea with 37 centers with 5,500 patients who were event-free under dual antiplatelet therapy after PCI for 6 to 18 months. And then these patients were randomized to aspirin versus clopidogrel. And it reminds you of the Capri trial, for those of you who might remember this, and that it was the only trial that there was a evaluation between aspirin and clopidogrel head-to-head. And take a look at this. They had a net adverse clinical events with inclusion of all-cause mortality, non-fatal MI, stroke, readmission due to ACS, and major bleeding in favor of clopidogrel instead of aspirin. You might have said, well, it's the same, but actually you had a better result with clopidogrel monotherapy. So yes, this is a small study, maybe it's only all Asian, but it begs the question for us to now examine that maybe this is the next step, and this is something that we just sent to PCORI as a letter of intent to try to do a large-scale 30,000 patients to see whether it should be aspirin or clopidogrel when we go to monotherapy. Finally, I want to talk to you about atrial fibrillation and PCI. Here's a place where you need to drop the aspirin. And I think it's the place where we now have novel oral anticoagulants. You see the 4 trials that have been done, and I'm just due to the time, efforts, these patients are at a very high bleeding risk. And the oral anticoagulation is absolutely necessary for stroke prevention for their atrial fibrillation. And antiplatelet regimen is important for stent thrombosis. But note, some of these novel oral anticoagulants have already shown, because of the thrombin inhibition, some really important effects on stent-related or ischemic events. So the idea of dropping aspirin here is a very, very good one. And in the meta-analysis that was been performed with all of those studies that have shown that the novel oral anticoagulant-based strategies coupled with an aspirin-free strategy is associated with reduction in bleeding. And take a look at the intracranial hemorrhage reduction here. It's all the way to the left in favor of the novel oral anticoagulant in an aspirin-free strategy in this patient population. And the Ischemic events are all hovering around the line of unity. You worry a little bit about stent thrombosis when you see the point estimate in the wrong direction, underpowered for it, but it doesn't matter. You still may come back and say, maybe in some patients we should rethink dropping aspirin 100%. Does one size fit all? And sometimes it doesn't. And so importantly, when you look at the stent thrombosis numbers, 48 versus 28, when you go to a aspirin-free novel oral anticoagulant right off the bat, and I think it's important to note that the North American consensus takes that into account, allows you to go to triple therapy for a short period of time in those patients who are at high ischemic risk, multiple stents, very high ischemic risk, and low bleeding risk for about a month of triple therapy. But the default strategy in most patients is to drop the aspirin as soon as you can, go to a novel oral anticoagulant. And in those patients who are at a very high risk, you need to shorten even the duration of the clopidogrel or the P2Y12 inhibitor. What I want you to look at on this panel is what happens indefinitely. And indefinitely, aspirin goes away and patients go on oral anticoagulants alone, even if they had a stent or have coronary disease. So lastly, I want to talk to you about tertiary prevention. There were 2 trials. One is ongoing. Adaptable was just seen. This is in the real patient population, 2 different doses of aspirin. They randomized. Adaptable was a very, very pragmatic design. Eligible patients self-enrolling themselves to 81 versus 325 milligrams with no difference in their ischemic outcomes. And of course, interestingly, the bleeding seemed to be different than what you might have expected. At the end of the day, I think the take-home messages here for all of you, ladies and gentlemen, is that we shouldn't just get used to old therapies because it's easy. We shouldn't be just thinking, and we should constantly be thinking about the changing paradigm of what we have in front of us and how great and how far we have come, such that stacking therapies may not be the best thing. We should be rethinking how we treat our patients. So for sure, no overt cardiovascular, in the patients who have no overt cardiovascular disease, the large-scale trials really did not find the benefit for chronic aspirin use indefinitely. When you have coronary disease or undergo PCI, aspirin is the standard of care, but there are novel strategies for us to think about, and they're emerging, especially in these high-risk patients, and some of them are, of course, in dropping the aspirin and going to a P2Y12 monotherapy, and the ESC guidelines are also supporting this. So maybe retirement is just ahead, and I think we've really got to think about this, that the aspirin a day keeps the doctor away may be something that may be forgotten. Thank you so much for your attention.